Good afternoon. Good afternoon, everyone. I think we can go ahead and get started. So how many of you are losing steam? It's a pretty intense conference, but taking a lot from everything that we've seen. So really fantastic so far. So I've been asked to do a short introduction. I'm Claire Chase with the World Bank Water Practice. And I'm involved with this team. I participated in a workshop earlier this year, but really this is led by the group that you see on the bottom of the slide here, and they will be the ones that will be speaking today. So this session is about measuring sanitation-related experiences and implications for quality of life and gender equality. There will be discussions around two scales, and then we'll have a group discussion. So the aim of the event really is to summarize what the researchers and implementers have learned from applying these novel experiential measures for sanitation, and then really to hear from you to crowdsource, get your feedback and input into future priorities for policy, practice, and research in this area. So the real question here that we want to start with is, well, why measure experiences of sanitation? And, you know, traditionally, we've really focused mainly on the health outcomes as the end all be all for sanitation. But, you know, given that sanitation is really a user-based experience, it requires behavior change in many cases, understanding what those other experiences is really important for adoption and take-up of sanitation. And so the groups will get into much more detail, but just we can begin thinking about what are some of these other experiences, perhaps security, safety, privacy, discussed, things like this will be what we'll be talking about. So the two measures that will be discussed today, one is what is referred to as a gender-sensitive measure of experience, and the other is a gender-specific. So we just give a couple definitions here, what that means, and what are the distinctions. So gender-sensitive, meaning that it's designed for everybody. It's for diagnosing gender gaps, but it's not for addressing gender-specific issues, while the gender-specific is going to be designed for a specific gender, and it's not used for diagnosing those gaps, but it can help us to identify gender-specific issues. So just to keep those in mind as we go through the talks today. So this is an outline of what we'll be going through. So we'll hear from Sheila Sineroy on an overview and use cases of the ARISE scales. And then we'll hear from Ian Ross and Sheila Simiyu on the SanQoL-5 index. Tom Slaymaker from UNICEF is going to talk through the SDG 6 gender indicators. And then we'll look at the use cases for both ARISE and SanQoL-5, and then we'll have a plenary with some guiding discussions after the presentations. So I think with that, let me introduce Sheila Sineroy from Emory University. Thank you, Sheila.
This is can I, oops, start from the beginning instead of the end here. Do want to acknowledge all of these people that are on my final slide here, but I'm going to start here. Okay. Okay, great. Hi, everyone. I'm Sheila Sineroy from Emory University. Really excited to be here. Thank you for powering through the week and the day and joining us this afternoon. I'm here on behalf of a really fantastic team from Emory, as well as many partners who are listed on the acknowledgement slide. And I'll be talking about the ARISE scales. ARISE stands for Agency, Resources, and Institutional Structures for Sanitation-Related Empowerment. I'm only going to say that once, and we're going to just call them the ARISE scales. So when we talk about empowerment, this is the definition that we use for empowerment: the expansion of choice and the strengthening of voice through the transformation of power relations so women and girls have more control over their lives and futures. And what you're seeing here is a conceptual framework with 3 domains of empowerment. So empowerment is conceptualized as having these 3 domains of resources, agency, and institutional structures. And then within each domain, there are several subdomains. And the ARISE scales are designed to measure all of the subdomains that you're seeing here. And we'll talk about those in more detail. But first, just a little bit more background in terms of the impetus for the ARISE scales and why we felt there was a need for these measurement tools. Part of the impetus came from the systematic review that our group did on water sanitation and empowerment, where we synthesized evidence from 257 articles that all dealt with empowerment and water and sanitation in some way. And one of the things that we found was that there was a limited sort of conceptualization of empowerment. Only 17 of the 257 articles provided a definition or a conceptualization of empowerment. And at the same time, people were engaging with different aspects of empowerment in ways that were showing that there were gender-specific issues that needed to be addressed. There were negative impacts of poor wash conditions on women and girls' experiences, for example, related to safety and security, that people were documenting in these articles, but they were not measuring. There wasn't a systematic or standardized way to measure these impacts. So there was this clear interest in women and girls empowerment, lots and lots of articles, more and more every year that were being published. But there was a lack of a sort of consensus definition or operationalization, and a lack of tools to measure these aspects of empowerment. So we went about developing and validating the ARISE scales. And the 2 papers that are on the right there, the first one is the 2-city validation, and the bottom one is a preprint that's the 8-city validation. So the ARISE scales have been validated in the 8 cities that you see here across 5 countries with over 6,000 women. We went through this really extensive process to develop and validate these scales that I'm not going to go into in a lot of detail, but the details are in the papers, just to say that it was really important to us to make sure that these scales were measuring what we say they are measuring. And so the statistical analysis and all of the validation procedures have been done across these cities. And so what we ended up with through this process is these 16 scales. Each one can be used independently, or they can be used together in any combination. So you have 4 scales for this 4 subdomains in agency, 10 for the 10 subdomains in resources, and 2 for institutional structures. And the numbers in parentheses are the number of survey items or questions that are in each scale. So you can see that most of them can be measured with 5 to 10 items per scale. And in addition to the scales, we have menstruation-specific items. We didn't include questions on menstruation in the main scales because we wanted the scales to be applicable to all women. But obviously, menstruation is an important part of sanitation-related experiences, and so we have those as optional add-ons to the scales. And we also have short forms for any scale that has more than 10 items. So most of them can be measured with 5 to 10 items, but for the ones that have more than 10, there's a short form. So each of these 16 subdomains of empowerment can be measured with 5 to 10 items each. So in what situations would you want to use these scales? They could be used sort of as a baseline measure to identify gender-specific differences between populations or across neighborhoods. Say you have a geographic area that you're interested in and you want to identify For program planning purposes, a target population where levels of empowerment might be lower or higher, and then you want to build on that information. They can determine weak or strong subdomains of empowerment. Again, this can be used for your program design if you're thinking about, for example, norms related to women's involvement in sanitation initiatives. We have a scale for that. So you can measure whether norms are supportive of women's involvement in sanitation, and you can plan accordingly. Do you need to include more sort of program activities to transform those norms to increase support for women's involvement in sanitation initiatives? Using the scale at the outset can help you plan. And you can use the scales at the end, obviously, to evaluate program impacts by incorporating the tools into your baseline and endline measurements. So, and the scales have been validated for measurement invariance over time. That's an important thing to know, that the scales are measuring the same thing at different time points. And that's a requirement for scales to be used to measure impact over time. So there's different time points, different use cases. And just to provide an example, one example of how the scales are being used now is in the RISE program. RISE stands for Revitalizing Informal Settlements and Their Environments. This is a randomized control trial that's being done in 2 countries, in Indonesia and Fiji. It's a WASH infrastructure program where the intervention is at the community level. It includes household sanitation, but also community wetlands for black water management. So what you're seeing here, this photo is from Fiji, from Suva, Fiji, and this is one of the community wetlands that have been constructed in this program. And it's an RCT. It has the sort of standard outcomes that many WASH RCTs have around child health, pathogens, et cetera, et cetera. But because we all know that those are often null, there are additional outcomes that are being measured, and part of it is related to women's empowerment, because RISE has this unique participatory component to their intervention, where they have this intensive participatory design process that is intentionally very inclusive, where they try to bring everyone's voices into the design of the infrastructure. And that includes all community members, including women. So they have this process where they are trying to get women's input into how the infrastructure is designed. And so there are potential co-benefits from that process. And so they're using 4 of the ARISE scales: decision-making, collective action, leadership, and relations, because there's this recognition that as women are involved in these infrastructure decisions, that may have broader implications, right? That might have an empowering impact on women's decision-making more generally. Women are being brought together in this participatory process, so that may increase their collective action. They might have leadership roles. There's an intentional aspect of the program where they are interacting with government service providers who are then responsible for the WASH services. And so those types of relations with key stakeholders in their community could also be improved. So those 4 scales were selected as being logical sort of priorities within RISE. So obviously every program would choose different scales based on what makes sense for them, their program activities, their context. In this particular program, those are the ones that make sense. Some other examples: there's a World Bank funded program in Mozambique that is a citywide sanitation program, and the ARISE scales, 4 of the ARISE scales are being used in a baseline assessment there to see with the intention that they'll be used again at endline to see if there are impacts on women's empowerment through this citywide program. There are lots of other research examples that are in the pipeline. People may have seen some presentations. There was one on Monday where Thea Mink talked about the Association of Sanitation-Related Resources, and depression, anxiety, and mental well-being in several countries. We're looking at decision-making and well-being, so different aspects of resources and agency, and looking at how those might be related to women's well-being, mental health. And also we're using the menstruation-specific scales to look at menstruation-specific resources like financial control to purchase menstrual products, time to change menstrual materials, and heavy menstrual bleeding as an outcome. So there are different health outcomes that people can look at in relation to these different aspects of empowerment. And finally, the ARISE scales informed the measures for gender-specific indicators for the JMP monitoring, which Tom will talk about later. So how can you access the scales? How can you start using the scales? We are launching the ARISE user guide. This QR code should take you to the guide. It's on our website. And so within the guide, we have all the definitions for the 16 different subdomains of sanitation-related empowerment, as well as the menstruation-specific definitions. So these are all definitions of different aspects, subdomains of empowerment that we have tailored to be specific to sanitation. And then for each one, we go through the scale. So this is the privacy scale. As you can see, it's 5 items. We have the survey item, the response options, a little bit more information about what is being captured. There's information about scoring. How do you calculate a score for this scale? And then we have frequently asked questions as well. So again, all of this is on the website, the Muse Project website. It's museproject.org, but that QR code should take you there. And that's everything that I wanted to cover today. I want to be sure to acknowledge our funder, the Gates Foundation. My co-PI on this project is Dr. Bethany Caruso at Emory, and we have lots and lots of really fantastic partners across the 5 countries, the 8 cities in the 5 countries who have contributed to this work. And the QR codes on the right are for different papers that have come out of this work so far. So thank you, and happy to take questions.
Hi, I'm Danny Barrington. I'm at University of Western Australia. Thanks for a great presentation. This is really cool work. In terms of the menstruation scales, I was wondering whether you think that they are able to capture experiences related to perimenopause, or if that's something that could be included with more research.
That is a fantastic question. We have thought about them in relation to heavy menstrual bleeding, as I mentioned, have not thought about them specifically in relation to perimenopause, but I think a lot of it would still apply because, like I mentioned, time, one of the scales is control over time to meet menstruation-related needs. So that would apply in perimenopause when needs may be changing, people may experience, again, heavy menstrual bleeding is something that can come on during perimenopause. So I think I would have to think about it a little bit more, but the scales are designed to be applicable to any sort of menstruation need in relation to sanitation, women's experiences meeting their menstruation needs in relation to sanitation.
Yeah, I was thinking about like extra washing.
Exactly. Yes. Yeah. So yeah.
Not just washing of pads, but themselves.
Right. Exactly. So that again might fall under time, but could fall under other resources as well. So yes, I think there are ways that they should be applicable. I would need to think a little bit more specifically about perimenopause, but yeah, that's a great question. Thanks.
Did you do cognitive testing as part of the validation?
We did,
Are there
yes.
any insights from that process?
Great question. Yeah, we did cognitive testing not in every single city, but in several of the cities. And there is actually a paper that came out of just the cognitive testing. It was led by Rinchen Doma, who was a master's student, and so she wrote the paper as her thesis. And then it was published the next year. It was really helpful. That was one of the, of course, earliest stages of the scale development. And so, yes, in terms of helping us understand the local relevance, we want these scales to be applicable across all of these settings. So trying to understand which concepts will be relevant to women everywhere across all of these urban settings, across all of these countries and contexts, that was really helpful. And of course, helpful for sort of translation and things like that as well. But yes, for refining the initial refinement of the scales, yes. Thank you.
Okay, there will be time for more questions, I think, later, if others come up with some. Okay, so now we will hear from, well, by the way, that was amazing. I'm so glad to see all the progress on the scale. It's really interesting. So now let's turn to Ian Ross from London School of Hygiene and Tropical Medicine, and you will co-present with Sheila Simiyu from the African Population Health and Research Center.
That's correct. Okay, hi everybody. Sheila, let's just check we can still hear you. Are you there, Sheila? Some of you?
I am.
Perfect. Okay, so we're going to do a little double act. I'm going to hand over to Sheila in the middle. Hi, my name's Ian Ross from London School. The work I'm going to show you has involved way too many organizations for me to fit all of the logos on. But so Sheila is from APHRC, the African Population and Health Research Center. And we're going to talk about a slightly different measure, an index of sanitation-related quality of life that does things slightly different to ARISE, but they're basically complementary and they're doing very different things. So the kind of, I guess, the overarching theory that we're working from is quality of life. What do we mean by that? We're following SEN's capability approach. So under that theory, people have a good life if they're free to be and do things in life they value. So that means anything that's valuable to you in your life, that's part of your quality of life. So we might work from a theory like on the right of these blue boxes, better in sanitation improves quality of life, but there's subdomains of quality of life which are maybe more related. So the things that people value about sanitation, I'm sure health is one of them, but there are other things, I think, many of which were mentioned by Sheila Simiyu, so privacy, safety, and others. So what way we think about sanitation-related quality of life is like a Venn diagram. It's the subset of overall quality of life, which is directly related to sanitation practices and services. Okay. And there are also ways, if you think about having improved toilet, you move up the sanitation ladder, the way that affects your quality of life might be moderated by certain characteristics of you or of your social or environment. So gender is an important one of those. Different people might experience toilets differently. Your gender might influence whether a new sanitation service, different people might experience that differently. Like your age would also be a factor, disability, and so on. So that's how we think about gender in the context of SanQoL-5. It's really a moderator. So these are the 5 questions. I've got some leaflets which I'll put at the front. So if you want to look at the questions in more detail, you can do that afterwards. If I just pick one of them, privacy. So the questions are framed out, they're all framed as how often do you X? So privacy, how often do you worry about being seen while using the toilet? And we invite questions on a 3-level response scale. So always is bad. How often do you worry about being seen? Always, we don't want that. We want never, right? So never is the best possible outcome. Always is the worst. Sometimes it's in the middle. And there's a separate set of questions for the same framing, but with open defecation instead of using a toilet. And there's a 30-day recall. What we do with those responses is, if you do the maths, there's, I think, 243 possible combinations of those responses. And what we do is turn that into an index between 0 and 1. So 0 is the worst, 1 is the best. It's gender sensitive, meaning if for the reasons Claire explained, it can be used by anybody, but it's it's also addressing outcomes which are important to all genders. The origins of the questions are in qualitative research in Mozambique, which included women and men as subsamples in the literature review. And it's a slightly different theory behind the development of the index compared to sort of scale. It's not a scale, it's an index. So it comes from health economics, I guess, theory, where the attributes are the attributes are chosen primarily for content validity more than anything else. So that's how we arrived at them, and I can talk more about that if you want afterwards. We've also validated this index now in 6 countries. The preprint I can give a link to, but it's ACTA 2024. Looking across the 6 countries where we have data, that are in that paper, you see a correlation with, I mean, there's many ways that we validate it using different types of validity, but this I think is the one that helps people think about it. So if you practice open defecation in that sample, then it's the lowest score, 0.35. And as you progress up the sanitation ladder, the mean SanQoL-5 index tends to increase. So this is, I guess, what we'd expect. But I guess the big jump between OD and unimproved is quite notable. So it has been used, to my knowledge, 15 times or in 15 data sets. But in fact, even today, I found someone told me they'd used it as well. So I need to update this map. But I just want to, I'm not going to read these all out, but I'm just going to flag that there's lots of places around the world. And also there's 3 main types of study or work which have used them. Impact evaluation, which I'd kind of classify loosely as like anything where you're trying to see an effect of some intervention on some outcome. So different study designs in there. Other academic study designs, and then monitoring and evaluation. I think Ed Mitchell's going to talk a bit about WSUP later, and World Vision have been using it as well for their M&E in some places. So we haven't yet validated it in all of these places. We've only done it in the data sets where we have enough, where the sample size is big enough for that to be a realistic prospect. So I'm just going to go through 1 or 2 of the uses and then hand over to Sheila Smiyu. So for the impact evaluation side of things, what we're really interested in is if you change someone's level of sanitation, or if you do an intervention to increase uptake of sanitation of some kind, what does that do to SanQoL-5? And these are, I don't have time to go through these, but we've basically, the people who have used them have found it useful to sort of characterize the extent to which outcomes have improved. The Malawi one was presented by Kondwani the other day here. There was a 0.15 increase in SanQoL, which you can think of as like a 15 percentage point improvement. The sort of spider diagram on the bottom right is from WSUP Clean Team Ghana, and they found it useful to be able to see an increase across all 5 attributes of SanQoL. So we can use, the idea of this is we can say, different interventions improve outcomes to different extents. And if you have maybe two competing program designs you want to compare, you could use SanQoL to say, okay, this one is more effective at improving quality of life than the other one. And you would obviously include any other outcomes that might be important to you as well. The second use case I'd flag is in benefit cost analysis. I presented this yesterday, but what we did was took that Malawi result, that 0.15 improvement in SanQoL, and then we were able to use willingness to pay to put a dollar value on that improvement. So that, that is, if you look at these results, we've got costs on the right in the sort of orange colors, benefits on the left in the green colors. And if you didn't have those quality of life gains, then the cost would be more or less equaling the benefits. But the fact we've managed to capture those quality of life gains, elicit people's willing to pay for that, and add that on top as a new bar, then we've sort of captured a broader aspect of the intervention's benefits. Oh, it's missing. Sorry, yes. That's open defecation time savings. Okay, so that's use case number 2. And now I'm going to hand over to Sheila for number 3. And I need to drag her over here. Oops. And I'll have to hide. Okay. I need to pin her actually as well. Let me do that first. It never worked. Okay, I'm not going to pin her. I'm just going to move her. Okay, Sheila, you can start while I'm dragging you.
All right, thanks, Ian. And good afternoon, everybody. And I'll just continue from where Ian has stopped. So the third way that we have used SanQoL-5 is in really trying to understand differences in gender gaps between men and women. And over the last couple of months, we have been implementing a study to really understand if there are any differences between men and women in terms of sanitation quality of life. And we've done this in 2 countries. So that is in Kenya and in India. In Kenya, we selected respondents from various counties within the country. And in India, we selected 2 states, that is Bihar and Uttar Pradesh. Next slide. Okay, so really, in terms of really trying to understand the differences, we select in each household, we select a man and a woman, so that then we are able to see if there are any differences within a house. And so this graph really tries to explain what we are trying to do. So assuming that the columns are households, so we select like a household, so that is household 1, 2, and 3. And in each household, we would select a man and a woman to answer the questions. And that really basically means that we are able to understand if there are any differences within the households. And that is what is represented by the green lines. Again, we still look at any differences across the household. So that is what is represented by the blue line. So moving forward, when you see the green lines, we'll be looking at any differences within the household, that is between the men and the women, and any differences across the household. So what we do is to get the score, SanQoL score, of the woman, and we subtract it from the man's score. And if it is positive, then it means that the man is better off. Next slide, Ian. All right, so I want to show how this is going to be explained so that then we are all on the same page. Like we've seen, the score is between 0 and 1, and I've said we'll subtract the score so that if it's positive, the men are better off, and if it's negative, the women are better off. So at the middle point is a 0. That means that there is no difference or there's no gender gap. And if we move to the right, which means men are better off, if the lines move to the left, it means that women are better off. Again, the green lines represent differences within a household, and the blue lines represent differences across the household. So within households and across households. Next slide. All right, so giving you a snippet of some of the results from India. Just again, we can't summarize everything, we can't show everything, but we'll just give you a feel of what we found. In India, we seem to see that there is an indication of a gender gap, both within the households and across the households. As you can see, the green lines and the blue lines are all on the right side, which means that men are better off in the overall sanitation quality of life index. And the graph below shows the differences in the levels of service, in the sanitation levels of service. So as you can see also, the lines tend to be towards the right, which means that there also is indication that the men are better off in terms of the different levels of service. And also just looking at the different lines, you can see that there's a big difference, or there's a big gap in terms of the lowest level of service, that is open defecation. However, looking at those lines, you see that the gap also decreases as you move up the levels of service, which is also indicative that as we move up the sanitation service level, then we tend to move towards closing the gender gap between men and women. Next slide. Now, moving to Kenya, the results seem to be a little different. So in Kenya, we are seeing, if you look at the blue lines and the green lines and where they are, we seem to see that there's a difference. There's no difference actually between the men and the women. This is in the overall sanitation quality of life, which is what is represented by the graph at the top. And if you also look at the graph at the bottom, we also see indication that they may not be evidence of differences in terms of the different levels of service in Kenya. but specifically just looking at the level of service in terms of the open defecation and moving up to the limited service and up to the basic level of service, we are seeing that there is indication that the differences that we are seeing in the overall quality of life could be as a result of the limited kind of service that we are seeing across the households. So that is basically the results from the study that we've done, and I think I can hand over back to you, Ian, to continue with the rest. Thank you.
Right, thank you so much, Sheila. This is the last slide, I think. So Sheila presented the results from that included that intra-household comparison into 2 countries. We also ran this analysis on 2 other data sets that we had, which were gender balanced, so we were able to look, but this is only cross-household, so you can only see the blue bars on here. And I guess again, it's a mixed picture. In Ethiopia, we did see that gender gap across households in SanQoL-5, but in Mozambique, there wasn't a gap. So I guess, and we have yet to do the analysis where we do it by level of service. So we'll do that. But I guess the message is that in places where that level of service gap is there and it's decreasing as you move up the sanitation ladder, that means that if we improve sanitation, that should decrease gender inequality over time, hopefully. So in conclusion, if we're going to understand gender inequality in sanitation, we need to measure it. And SanQoL-5 is one way of doing it. There's lots of other ways of doing that. It's 5 questions. It takes 1 minute. So we're hoping that more and more organizations might add it to their routine M&E, monitoring and evaluation, so that then they can learn things from that. Or if people are running trials, sanitation trials or evaluations, they could include it in that as well. It's quite simple to do. And then we can hopefully generate more evidence that that improving sanitation is good for gender equality, which I think we all implicitly think we know, but the more that we can demonstrate it, the better. And the more that we can identify which interventions are best at improving gender inequality, the better as well. So thank you very much for listening. So yeah, we've got 2 minutes for questions before we move on. Where's the mic gone? Yeah, and like we said, there'll be plenty at the end. So I'll just take 2 questions and then we'll crack on.
Thank you. That was super. Christian from Save the Children. Can you guess my question?
Go on.
So no, I was interested if there's been any discussion or any use of this looking at, I guess, what we could call age inequality. In many of the humanitarian contexts we work, the majority of the population are children, not men or women. And that would be really interesting to explore.
Yeah, it's a really good question. So we developed this with adults 18 plus because of reasons. But it is an aspiration in the future to try and develop a child version. A lot of the kind of indices that I sort of, the health ones in economics that I sort of look to, they have a youth version and a child version. I think right now it just hasn't been like the overwhelming priority to develop that, like for funding reasons as well. But I'm very happy. I'd be really interested to talk to you afterwards about like what might be the priority, what kind of things might you use it for, and we can try and get master students on the case to think about it and start doing proposals. So yeah, let's talk about it.
That'd be great. And it'd be really interesting to explore in humanitarian settings. Like, I don't know if some people know an Oxfam report from some years back from multiple responses that found that 40% of women weren't using the toilets that were constructed for a variety of reasons. So this tool could be quite useful in addressing that as well. So.
Cool. So one more question, then we should move on. Maybe the lady who hasn't spoken yet. Yeah.
Hi, I'm Aditi Krishna from IRIS Group. I have a small comment about the hypothesized gradient along sanitation levels. What I noted in your slide, and it was Sheila's last slide that you presented, was that your sample size for the limited category was quite small. It was something like 43, and the confidence interval is quite large because of that. I wonder in a sample where you've got a larger bucket for that, if the same patterning is true, and if you could more confidently say that there is a patterning according to the SDG levels.
Yeah, maybe I can start, and Sheila, if you want to supplement. So yeah, definitely it is a small, in India, it's a small bunch of people using shared toilets. The sampling for this was based on, it was to be representative. So we didn't do stratification by toilet type. We just got what we got. So definitely we're not confidently stating that there's a gradient. It seems like there might be one in India. It seems like there probably isn't one in Kenya, but it definitely warrants further investigation. So we're definitely not making grand claims. Sheila, do you want to add anything?
No, I
Oh,
think that's
she's gone.
great.
Okay. I don't know where your video went, but okay. We should move on, but then happy to answer more questions when we get to the plenary.
Thank you, Ian and Sheila. That was really nice work. Hope to speak more about it. And now I will invite Tom Slaymaker from UNICEF to talk about the SDG 6 gender indicators.
Should move that back.
Okay, thank you, Claire. So I'm Tom Slaymaker. I manage the UNICEF side of the JMP. My colleague Rick, who manages the WHO side, is here. And I'm going to talk about a collaboration that we've had with Emory University, with Sheila and the rest of the Emory team, to develop some priority gender-specific indicators for global monitoring of WASH. So this has been a long, sort of multi-year, multi-stakeholder, expert-driven process to arrive at that priority list. And you may be aware that in 2023, we did a progress update which had a special focus on gender. And of course, for the JMP, what we're ultimately interested in is national level data. We want to do cross-country comparison. And for these indicators that we're talking about here, it's really hard to find examples. So we've got lots of great small studies, but trying to find national level data is a big challenge. So just to give you a bit of background on the process, it was essentially done in 2 phases, and it's all documented. So you can go and find this on our website if you're interested. So there was quite an extensive literature review to arrive at a conceptual framework, looking at other conceptual frameworks that are already out there, including ARISE and others. But essentially to create a framework on which to hang the review. And then an inventory of tools. I think there were over 76 tools in total, with a very large number of subdomains and elements within them. So there was an inventory created, and then there was a process of expert consultation to look at those tools, assess the extent to which they addressed the different domains in the conceptual framework, and to identify those where there are kind of big gaps where we might like to develop new indicators in future. So there's a report of phase 1, but it's essentially showing us that there's a very large number of different ways in which gender can be addressed, a lot of different frameworks. And the conclusion was the need to narrow it down. So phase 2 then was all about prioritization. It's quite an interesting and innovative approach to prioritization. So this was a smaller expert group, which was tasked with looking at this inventory of tools and whittling it down, ranking all of the different dimensions, and then looking at each of the indicators, but also the different items within those indicators to see how they correspond to the domains in the conceptual framework. And then once there was a draft list, that was then put out to a process of sort of public open consultation to get additional feedback. And then ultimately finalized towards the end of last year. It's down to a list of 15 indicators, which you can find in this document, which is on our website, which was finally sort of laid out and published in March. So the document not only lists the indicators, but it gives you a bit more background on the rationale behind their selection, how they can be measured and monitored, and some notes for data collection. It's covering water, sanitation, and hygiene, but also menstrual health. And it's a priority list. So of course, it's not comprehensive, it's not exhaustive, it's mainly focused on the household and the individual level. Some of these have been tested, validated, and used already. Some of them have not yet and need some further testing before they can be used. Some of them can already be calculated based on existing data, whereas others will need new data to be collected. So it's a good starting point for us to then think about how we can move forward. So I've just highlighted here some examples on sanitation and menstrual health, just to illustrate. So here the three measures, which I can't see on my screen because it's so small. So we have one for sanitation related to the ability to meet basic needs, proportion of individuals who reported that the sanitation location they used most often in the last 4 weeks was clean, private, and safe. And that's disaggregated by sex and by age. And then we have 2 on safety and freedom from violence, 1 on the proportion of individuals who felt unsafe at the sanitation location they used most often, and another on the proportion of individuals who believe that women and girls in their community face risks. So these were the priority indicators. And then you get a bit of detail on the rationale behind them and the existing frameworks that they draw on, and most importantly, the precise definition, the numerator, the denominator, and the different items that you would need to be able to collect the information on this indicator. And you can see immediately that this one is related to the ARISE scales that we were hearing about earlier. So all of that information is in there. And then for the JMP, we then took this list, this framework of indicators, and we said, well, what do we have at the national level? What can we work with? What can we leverage the existing data? And I think you already know that we're measuring and monitoring limited sanitation, shared sanitation, globally as part of the SDG ladders. We know from all of the evidence and the frameworks and indeed the presentations we've just heard that shared sanitation disproportionately impacts women. And so we can use that as a proxy indicator, and we can use that to draw attention to those countries where we have very large numbers of people who are still using shared sanitation, especially in urban areas. But another interesting thing that we can do is to start to combine those data where we have information on shared sanitation with additional information that we have on the situation of men and women. So in a mixed household survey, we also have information on whether or not men and women feel safe walking alone after dark in their neighborhood. So in the report here, we have had a look at shared sanitation amongst those households using shared sanitation, the differences between men and women feeling safe after dark. And you can see, for example, Georgia there, quite a big difference between men and women feeling very safe. So I think 85% of men and only 47% of women. And some, some other countries with quite big differences. And also, if you look then at the proportion who feel very unsafe, women generally more likely to feel very unsafe. Now, of course, feeling unsafe in your neighborhood and sharing sanitation are 2 different things. So we ultimately want to get to safety around shared sanitation, but we can at least say something about the differences from the existing data. Menstrual health, another good example. We have 2 indicators here, which made it into the priority list. The proportion of individuals who menstruate, who changed their menstrual materials in a space at home that was clean, private, and safe, disaggregated by age and sex. And the proportion of individuals who menstruate who reported having enough materials to change as often as they liked during that last period, disaggregated by age. So these indicators have been collected for some time and have been included in household surveys since about 2018. So we analysed those in our update and looked at the extent to which we can use those to highlight the situation of women and girls. These are coming from individual questionnaires for women and girls aged 15 to 49. And I highlighted these earlier in the week because it's showing you that use of materials is relatively high. A private place to wash and change is a little bit lower, and participation in activities during menstruation is often significantly lower. But generally speaking, we're finding that these indicators are not are not sensitive enough to capture the problems that women and girls face. So we have been in parallel then developing a new module for Mix 7, which is just starting this year, which is going to go into a bit more depth and detail on this topic. We have a list of indicators there which are in the module, and we've highlighted the ones which relate to the priority list that was recommended by the experts. So the first one there, MH1, during your last menstrual period, did you worry that someone would see you while you were changing menstrual materials while at home? So it's getting to the privacy question. It's not getting to clean and safe, but it's addressing that priority issue that came up. And then the second is very closely related. So during your last menstrual period, did you have enough menstrual materials to change them as often as you wanted to throughout your menstrual period? So we're starting to get these indicators into survey programs, and once the data have been collected, we'll be able to start to analyze them, and it will tell us more and more about gender inequalities. So a few things. There's a priority list there. Some of them have been tested, but some of them haven't. We're looking to pilot them. We will be piloting them in Bangladesh and possibly also in South Africa. And if you're interested to pilot them and you'd like to work with us, then please let us know. We also want researchers to continue to test them and validate them, and we can refine them over time. We see this as a sort of a living document, but ultimately we want to encourage uptake at a national level so we can get nationwide data that we can ultimately use for cross-country comparison in JMP reports. There are a few resources there, including the QR code, so you can go and look at those later. And just a big thank you to all of those involved, including especially the Emory team who supported us with the review. Thank you very much.
Tanvir now. It's the video. So it's Tanvir on there, but he's not here.
Okay, so now we are going to hear from a video with Tamir Ahmad, who is from the Center for Water Supply and Waste Management in Bangladesh.
Hello, everybody. Thanks for giving me the opportunity to talk about the application of ARISE scales in Bangladesh. Bangladesh was included as a part of the MUSE study, where IT and BUET, along with our partner organizations, were involved in collecting the data in 2 cities. I think Sheila already explained the different applications for ARISE scales. I think I'm not going to go into this, but just to mention that in Bangladesh, we use the ARISE scale so far to assess baseline levels of sanitation-related empowerment, and particularly in the privacy, safety, decision-making, leadership domains. And we also did a bit of work on testing associations between empowerment domains and other outcomes like mental health and well-being for women. So we, as I mentioned, we did the study in 2 cities in Bangladesh. These are called Soedpur and Meherpur. Just to give a brief on the city profiles, Soedpur, both of them are Class A municipalities. One is slightly larger than the other. The population density is almost similar, although there is a difference between basic sanitation coverage. One has more coverage than the other, and also in terms of the LIC area, 90% has safe toilets in Soedpur, whereas 40% has safe toilets in Meher. Now, looking at the findings, what we have seen that Soedpur exhibits more positive trends than Meherpur across the different empowerment domains. And these where we looked at the decision-making roles in committees, whether it could be the confidence to hold positions equal to men in committees, using sanitation facilities or attending meetings outside the neighborhood without permission or accompaniment, We looked at conflict-free interaction with local leaders and feeling safe to use sanitation facilities and control over money and resources and having skills for sanitation projects. In all of these aspects, Soedpur showed better outcomes than Meherpur. Although this is not a longitudinal study, but there is a correlation between the time of sanitation intervention with some of these empowerment indicators. As I just mentioned here, that the sanitation intervention in Soedpur was in 2013, where sanitation interventions in Meherpur happened a bit far ahead in 2000. We also found some associations with mental well-being and decision-making roles in sanitation. For example, we found a positive association between well-being and individual decision-making factor scores. By decision-making factors, we mean ability to influence community-level sanitation decisions and make household sanitation decisions. We also found that better privacy, safety, time, bodily integrity were associated with lower anxiety. We also saw that better perceived privacy was associated with better well-being and lower anxiety and depression. So looking at what we have found is that we can see that these ARISE scales can help us see that the adequate sanitation goes beyond just safely managed sanitation, and it says that the infrastructure has to be private, appropriately located, and it meets the woman's needs and has to be safe. And we understand that sanitation investment can lead to a positive outcome in equity, as we have seen in the case of Soedpur and Meherpur. And sanitation-related experiences and perceptions and infrastructure associated with mental health. So all these can actually help us design and implement sanitation interventions. This can be a recommendation to the local government institutions. As you probably know, Bangladesh is currently making a lot of investment in sanitation and waste management, especially in the small cities. Construction of FSTPs, public toilets, trying to make them gender friendly, and also developing women entrepreneurs. So many of these findings from this study can be used to design and implement sanitation-related interventions. It basically says that women needs to be incorporated in sanitation decision-making as much as possible in the context. I believe that we only brushed the surface on testing the association of mental health and well-being of women and sanitation interventions. And I think that there is more to it, but we just primarily looked at it, and this can be dug further into. There are also many associations that can be tested using the large data sets we collected in the Muse study. So I think there is prospect of further looking at interesting associations. So that's all from me. Thank you very much for giving me the time. And I apologize for not being there in person in the panel, despite being there physically at the conference, as I had a clash with another side event. But I shall make sure to catch up with you later. Thank you very much.
And I'd like to invite Ed Mitchell from WhatsApp to talk about the use case for the SanQoL-5.
Thank you very much. And it's quite entertaining because he's literally in the mirror room to this room as we speak. So I've not gone with slides. I'm not sure. I might regret that because some of those slides have been excellent that we've had so far. But I just wanted to talk a little bit about the use case and why we in WhatsApp think around SanQoL in particular, and our experience with that and why we intend to use it more in the future. So for those of you who don't know us, WhatsApp is an organization that specializes in wash provision in low-income communities in urban settings in particular, with a focus on systems change so that the interventions that we make are sustainable and the service continues long after we've disappeared. So we've used SanQoL, I think, 2 occasions and currently using it in a third. One is, and the 2 I'm going to talk about were both carried out by independent third parties rather than our own staff, but I'll come back to that in a minute. One was around intervention around provision of high quality shared sanitation in Maputo, Mozambique, and I'll again come back to that in a second. And the other one for our container-based sanitation subsidiary in Kumasi in Ghana, so Clean Team Ghana. And I think we've always felt that, I mean, several people have said this, but we've always felt that the sort of interventions we make are gender positive, but we've often found it difficult to describe that and articulate it and measure it. So we were interested in doing that. And in Kumasi, we did a survey where we surveyed people's quality of life indicators around sanitation immediately before installing the container-based toilet and then 10 weeks later. And we got a 0.27 point improvement. So remember the scale is 0 to 1, so that's roughly a 27% improvement. It was 292 customers, and we combined it with interviews and focus groups, as or the people who did it for us did. What was interesting was the gender implications of this. So as well as seeing quite a strong improvement in all 5 SanQoL questions before and after intervention, we also saw a swapping of the male-female ratio of satisfaction before and after. So before the interventions, men were significantly more comfortable with the sanitation provision, which was largely public shared toilets. After the intervention, i.e. when they got a container-based toilet in their home, it swapped round and the women were more satisfied than the men, but both saw a very big increase. So quite interesting from that point of view. And we always felt that the market for our container-based solution in Kumasi was probably particularly suitable for people of limited mobility or people who needed to use the toilets at night and didn't feel comfortable going to public toilets, and also reflecting that the majority of people are tenants rather than landowners, so their ability to install some sort of more a permanent sanitation solution wasn't there because it's not up to them, it's up to the landlord. In terms of the Mozambique example under MapSan, we looked at 424 households and there saw a 0.34 point movement, so 34% increase. Again, we did, I can't remember actually whether we looked at the male-female ratios on that, but we got enough confidence from these 2 trials to want to use it much more widely and to incorporate it into our overall M&E framework. So we're just approaching it. We tend to strategize in 5-year periods, and our next strategy runs from 2025 to 2030, coinciding obviously with the SDGs. And with that, we're revising our M&E framework, and we're going to include the SanQoL methodology within that as one of a menu of options to be used by teams depending on the circumstances. And just to sort of talk through the reasoning for that, which others have mentioned as well, I think it feels obvious that there are quality of life benefits from improved sanitation, but also that those are underreported and under-recognized. And so that's not to downplay the health benefits, which are also incredibly important, but to make the case, a wider case for a more holistic case for the need for improved sanitation. I think it's important to recognize the quality of life aspects as well as the health aspects. The health aspects are, of course, also incredibly important, and that MapSan trial, some of you will have heard about on different occasions here this week and also last week. We are genuinely very excited about it. It was a 60-month, 2 surveys 5 years apart, carried out by UNC, based around children born into compounds with improved, high quality improved shared sanitation. And they found a very significant improvement in terms of reduction in stunting, which is a really exciting finding in terms of making the case for good quality shared sanitation being a really important intervention. So I think I only had 5 minutes. So I'm probably just going to draw it to close there. And we've obviously got the panel discussion now. So I think I go and sit down over there. And I look forward to the questions and comments about that in a minute.
Thank you so much, Ed. And I realize we also didn't open for questions for Tom. So if there are questions for Ed or Tom, and unfortunately, Tanvir not here, then please, we can start with those, just a few minutes for questions. And if not, then you get to the hard questions, which are, so we wanted to structure this plenary discussion around these 2 questions that you see on the screen here. So thinking about the work that you are doing and your context, what do you see as opportunities to apply these measures? What are some ideas that you may have for these, for the researchers? And then what resources would help to support those efforts?
Can you use this mic?
So, thanks. Just one, that was great from all of you guys, but just I had a question for Ian from your presentation.
Yeah.
Is there a reason why all of the 5 questions are negatively framed? And did you do any testing on the differences between positively and negatively framed questions?
Thanks. Yeah, that's a really important question. So, and in fact, it was cognitive interviewing that helped us decide what to do. So originally the questions were framed in a different way when we did the first validation. And in Portuguese, which is the language in Mozambique, where we did the first validation, it worked and everybody was happy in the cognitive interviews and the survey itself. But then when we started piloting it in other places like Zambia and Ethiopia, in those translations, the framing struggled a lot more. So we switched the framing to be this way, which it used to be, can you use the toilet without feeling disgusted? So in some languages, that's like a double negative and it didn't work. Because we were trying to link very closely to sort of capability theory about can you X, can you Y? So the new framing is how often do you worry about X? So it's negatively framed because it was felt in the cognitive work that was just more straightforward for people to understand. So all of the outcomes are, I mean, they're not all bad. Like disgust is bad and safety is good and privacy is good, but we framed all the questions so that the response categories were always consistent, like always is bad, never is good. So it was like a learning process, and we learned a lot from colleagues along the way and the different translations, and that's how we got to where we are. And we're pretty confident now from the cognitive that we did in Zambia that it works well. And so far we haven't had any, since we made the change about 3 years ago now, we haven't had any more problems. Does that answer?
Anybody have a question or? Yeah.
Thank you for the presentation. I was just thinking, like, during all the presentation, either it's from ARISE or SAN quality of life or the JMP priority indicators, You all presented that it's for different reasons, but there's a lot of overlapping. I'm just thinking in case of like a local government or practitioners, for example, the ARISE also had a short form of indicators for sanitation related experience, and JMP also had the priority indicator, which are like kind of similar for me. Maybe like I need to go into the resource and look into the details for now, but for a local government or practitioners who have a limited budget and they want to measure something, it's again the thing of like we have so many options, and is there a way to come together to integrate this thing in one place? Like, should I do the JMP now or the ARISE one? Because I see like a lot of similarities as a local government or practitioners who have a really limited budget in the ground. So I may have to go into the details on what are the rationale behind all these indicators, but I'm just seeing a lot of overlaps. And how do we like convince a local government just to do this if we have a limited budget, or should we just do all the indicators? Or yeah.
Sure. Yeah, I'm
We should
sure.
probably all talk about
Yeah,
this.
we could each. I'm sure we each have an answer for this. Yeah, it's a great question. I would say it really depends on the context and the priorities of the government, right? So, you know, in some places, it may be that safety is a real issue, right? Women's safety is a real issue when they're accessing shared sanitation. So in that case, the government may want to prioritize asking about safety and focusing on women's safety as a specific issue that they are targeting. And then eventually they may shift, you know, once that issue has been addressed, it may not need to be prioritized anymore. And then the questions that are asked may be different. So I think in that sense, you know, there's that consideration. There may also be a consideration towards, are they collecting data that's then going to feed into national data? In which case they would want to, you know, maybe use the JMP indicators so that they can be contributing to that national level monitoring. So there may be, you know, some other priority that's coming from above. It doesn't necessarily answer your question, but I think it is very contextual.
Yeah, I think it's a good answer. What would I add? So, yeah, I mean, what's important is context specific, but also what already exists. So the idea, I think, of the priority indicators is to give a sense of indicators that would be important in all contexts. But some of those may already exist, or some of them may be more important than others. But beyond that, I think it's about what data sources exist that could potentially be used to collect these indicators, and that also differs across contexts. So it may be that some of these can be more readily added to an existing data collection mechanism than others. So whether that's a household survey or a phone survey or some other data collection exercise, all of those factors need to be taken into account. So yeah, there's no kind of blueprint. I think there is very good alignment, actually, between the JMP priority ones and the ARISE scale. The SanQoL wasn't around when we did the reviews, Ian, sorry about that. But yeah, I don't think there is a contradiction. But yeah, you have to decide based on the level that you're working and what you're trying to achieve.
Yeah, I think I'd just add to that from a, in our case, the critical thing is demonstrating a before and after, not necessarily trying to assess the state of sanitation in a particular location, but have our interventions significantly improved something, and specifically has that had a positive gender impact in improving those. So that's what, and the other thing is as Ian said, the SanQoL is very quick to use, and that means cost effective. So for those of us that are living on restricted grant funding, that's an important consideration. So I think each organization and for each purpose, there will be different drivers, but that's just to explain why we're particularly interested in that one.
Thanks. I basically agree with what everyone said, but I've got a few extra things. So I would generalize what people are saying is like, it's horses for courses. We say in English, it depends what you want to do. Like if you want to look at women specifically and you want to look in a lot of detail, then you should use ARISE. If you want to just answer like 1 or 2 questions and align with national monitoring, then the JMP ones might be the way to go. If if you want to look sort of across all, well, various domains of quality of life, as I would put it, and you would like to have a single score, then the SanQoL-5 might be the way to go. So it kind of depends what you're trying to do. They'll have different aims, and we're all biased towards our own ones, of course. So there's also, yeah, I said that one. And just to flag that in the JMP guidance that they put out recently that Tom mentioned about different indicators for measuring those different questions for measuring those indicators, both ARISE and SanQoL-5 are in there as sort of possible ways to get at privacy or safety. So I don't think everyone's bottomed out on like the one question yet, and we're all going to carry on using these different questions, and hopefully maybe in 5 years there might be some coalescing around something. But for now, it's horses for courses.
So I want to ask if anybody has any ideas about opportunities to apply the measures. Yes, okay.
Hi, my name's Samuel Taylor. I work with ACIS Environmental Consultancy, and we basically improve pit latrines to on-site treatment systems. Currently, we're working in Bangladesh, but we are trying to expand. We're going to be expanding into Kenya as well. So I would like to sort of know like what kinds of, sort of satisfaction and how to measure sort of, the increase in quality of life, the increase in satisfaction, the increase in well-being, to quantify this, like when somebody is able to convert their unsafely managed pit latrine into a safely managed on-site treatment system.
Can go in order again,
Yeah.
maybe. Yeah, it's a great question. I think one thing that we come back to, I think all of us talk about is, and I think Tanvir mentioned it in his presentation, that all the aspects of experience that are not captured when we talk about safely managed systems, right? So privacy, bodily integrity is one of the concepts that we talk about in ARISE, which is sort of your control, your feeling of control over your body. Are you able to meet your bodily needs when and as you want to? So, I would say those aspects of the experience are important to measure in addition to, going from the different treatment systems. That's one aspect of, the experience that you're measuring, but then these other aspects of that contribute to quality of life, I would say those are really important to capture as well. And I think somebody mentioned that, there was it you, Ed, who said there was a project where a lot of women then didn't use the latrines that were built. We see that all the time. I mean, we see lots and lots of examples all over the world where women choose not to use the facilities that are constructed. And it's because those facilities don't meet their needs, the experience that they want and need to have. So those sort of needs need to be addressed, and you can capture whether you are meeting those.
We just go along. So yeah, thanks. The transition you're describing is essentially the one that was achieved in the MapSan study, which Ed mentioned. So from unimproved low quality toilets to a high quality septic tank on the same site. So nothing else changed, like the neighborhood safety was the same. People were the same. All the change was the toilet to being upgraded. So, and they saw changes across the board on all 5 dimensions of SanQoL. But if it was purely like just a containment issue that changed, then maybe, the superstructure was the same. Then, maybe you expect to show that to show up in the discussed attribute, possibly if there's fewer smells coming from the toilet. Yeah. Can I just, while we're going along, can someone check the online? I don't know if we've looked at.
Thanks. I mean, I was going to say what you said, Ian, really, which is you can have a very shiny user interface and a very dodgy treatment piece, or vice versa. And what SanQoL does is it will primarily pick up on the feeling of satisfaction with the cubicle or the top bit. Yeah. There are lots of other reasons why you want to improve the below ground piece, around environmental sustainability and possible wider health impacts and all sorts. But the two are not not necessarily closely related, I think.
No, but I think it's still a good question and we don't know the answer. So it would be interesting, I think, to apply these scales to higher levels of service in the way that Ian has done already for the sort of basic and below. I think we have to think of these scales as complementary to, you know, the existing measures of service levels, but they will help us to get at things like, you know, the difference between high quality and low quality shared sanitation, as Ed's been emphasizing, and that's really important. But we might also see, you know, some very significant differences around open defecation in some countries, especially where that's very widespread. And we could think even about, you know, applying these sorts of things outside of households. So similar approach, but, you know, looking at wash service levels in schools or healthcare facilities, for example. I think the same basic principles would apply. And it would be interesting to see the extent to which there are significant gender differences. The one thing I was reflecting on is, well, two things actually. One is, you know, whether you only look at women or you look at women and men together. And if you're trying to evaluate something, you want to capture both because the total benefit is going to be more. But also changes over time. And so you did before and after. And I don't think we have any examples of a long time series. So I wonder how much of the change in, I don't want to say satisfaction, but, you know, is a short-term phenomenon and how much of it would be sustained. Might be something to talk about.
I think you're going to check online, but I did add Sheila. I moved Sheila Samir over there, and I'm not sure if you're there, Sheila, but you're also on the panel if you want to jump in on anything. If you are still there. So over to you, Claire. Okay. No questions online. All right. There's another one there.
There's still a question on the screen, right? There's still the question there. So I'm Maarten from Emory, South Africa. We are implementing multiple market-based sanitation programs in East Africa, Southern Africa. So I'm trying to answer the question. I thought, yeah, and it's. I think looking at we have rolling projects that we go from one district to another, starting market-based sanitation programs, and in that case, it's easy to. I see that it's easy to replace a couple of questions that we already asked about how people perceive usage of a latrine at baseline and endline with the question of the SanQoL-5. I would personally add the JMP also to, as we also measure these sanitation service levels already in hygiene, so to add them in that perspective. And I would also be tempted to imply then, apart from the sanitation program, we also work quite a lot in healthcare facilities and upgrading, etc. And I would also see it fits to use it there. And as explained, in cases where we really work in programs which evolves around empowerment, then indeed ARISE is a very good tool to identify what are the priority areas to sit in. But looking from a WASH perspective, most of it is really then the SanQoL-5 and JMP is pretty fit. So the only thing that there is, which is already a problem, so that has nothing to do with the tools, is of course the actual behavior that people have at baseline and endline. It's about perceiving safety and privacy. And it's not whether they actually use it or whether it's a burden to use it or not, or whether there's no problem at all, whether they actually still use it or just give nice answers, despite the fact that it's negatively put. So behavior is still, and that's still a problem, of course, even today. So that has nothing to do with the tools. Thanks.
No, that's perfect. And can I just add to that, because I think it did come up a couple times, but the non-household settings, can maybe you speak to application, applicability of the index and scale to household, healthcare facilities and schools specifically?
So I can just add on that one, if Ms. Sheila, you. So there's a team at Northwestern and other places developing an institutional WASH scale, like it's called InWise. So I think, like, because they're doing that, I wouldn't sort of try and generate. I mean, we're not thinking about doing a SanQoL for for healthcare facilities. For that reason, there's no point duplicating there because it is also quite short. So I'd say if you're interested in measuring these kind of outcomes in schools and healthcare facilities, wait for the INWISE would be my recommendation.
Just with the JMP indicators on the menstruation ones that you're thinking of adding, are they additional or replacing? I didn't get that. Were they additional
Yes.
or yeah, okay. Yeah, just with the one about worrying about if someone will see you. Just I think I don't know if it's pulled from the MPNS or if you know, but that's on the MPNS scale, that question. And so we use that question quite a bit in our work. And it's actually like one of a little bit of a confusing question for people. So just in terms of what resources would support that, like guidance for that one would probably need to be really like worry is not, it's like for us, it's been a not easily translatable concept. Like what is worry? And also that the idea of would you worry, it's like a hypothetical. It's not something that's tangible. So that's also been sort of a concept that has been interesting to, yeah. So it's just required like quite a bit of training, that question specifically. So just as a broad national level indicator, obviously, yeah, I guess interested how it is selected as well.
Yeah, it's a good point. So the new indicators, the new module, it does replace the old indicators. So there used to be 4 and now there are 6. And you can see which ones have evolved. So for example, on materials, it's about sufficiency. On, it's a private place to change and taking out the washing, because washing and changing are 2 separate things. So there have been various changes that have been made. And I think you're right. This was the recommended way of formulating the question. It comes from these existing surveys, and we've worked quite extensively with the mix team on developing guidance on how to ask these questions, things to look out for when you're translating them into other languages. So yeah, it'd be very interesting to follow up with you and see if you've found alternative formulations that work better, or certain types of guidance that has been helpful in certain cultures or certain languages where it's particularly confusing. So we'd really welcome that kind of information, because we can continue to refine the package of guidance as we move along. Exactly. Yeah.
Could I possibly ask a supplemental just on exactly that point? I was intrigued by why is it in the home only?
Because this is a household survey, and within the household, there's then a questionnaire for individual women who are aged 15 to 49. So then this question or this module will be added to some surveys, and it will refer to the household. Yeah.
Do you want to say anything?
So can I ask, we're at the end, but I think instead of me trying to sum up your expertise, can you just do a quick closing remark from each of you? And Sheila, also online, we'd like to hear from you.
Should we go in reverse order to start this time?
Well, thanks. I think it's a good discussion. I think the example I gave at the end about menstrual health shows how you can start with a set of indicators, and then they will evolve over time, and they will take into account feedback from people who've been using them in the field and found them useful or not useful. And I think we want to do the same with the gender indicators. And if anybody in the room would like to pick up these tools and work with them, and they would like support or guidance on how to do that, then we'd really like to hear from you. But this is a new area of measurement and monitoring, and it will take time before things settle down and we end up as a sector with things that we're all confident to recommend to government partners, but also other development partners.
I think for me, it's just encouraging to hear that these tools are available and to hear examples of them being used and it being relatively easy to use them for practitioners and people trying to get change on the ground. It's really helpful to have that choice of indicators and to be able to strengthen the case that we all need to make for why improved sanitation is such a priority. It seems so self-evident, but the more data, the more evidence, the more compelling arguments there are about the different aspects of why it's important, the better, frankly.
Sheila Sami, are you there? I think it's very late in Kenya, so she may have just gone to bed.
I'm here. I'm here.
Do you want to say anything?
Yes. Thanks for the opportunity. I think for me, I would echo everything that has been said by all of us. And the most interesting is, I think, looking to echo what both all of us have said, including what Thomas said about the need for more data and trying to get as more as we can so that then we can test and be able to validate some of these tools that we're using. But I'm also fascinated by one of the presenters who mentioned about whether we have tested these tools in humanitarian settings and looked at the age differences. And I think that's something that we can explore going further, looking at how the same tools or the different tools can be used to look at differences across the life course, as we call it. Otherwise, thanks for the opportunity, and hopefully there'll be a next time when we'll see each other in person. Thanks.
Thanks, Sheila. I think the thing I'd emphasize that I haven't talked much about SanQoL-5 is the single overall score. I think the way that I showed its use in impact evaluation and then the benefit cost piece, I guess that's one of the added values of it in being able to use in that purpose. Once you have something in one score in that way, it can be used for all kinds of other things like to weight stuff and so on. So I guess that's a distinction. I've got some leaflets down the front if people want to look at the questions and look at some more of the detail. And also just what Sheila just reminded me that we did actually use, one thing I need to add to the map, we have used SanQoL-5 in a humanitarian setting, and my colleague's writing up the paper now. So hopefully we'll be able to discuss how that worked or didn't work in that place.
Thanks. I know now we're past time, so I'm standing between people and their break. So just very quickly, I think we're all here because we recognize that there's more to sanitation than the treatment system. There's a whole range of experiences that people have in relation to sanitation, and we all want to measure those. So I just hope that these tools will be taken up, whichever one is appropriate for your context, your program, your setting, so that we will have more evidence on the whole range of experiences that people have when using sanitation, and so that we can advocate for sanitation that meets everybody's needs and preferences, regardless of gender or age or sex or, whatever the personal identity is, but just trying to improve the experience overall. So thanks, everyone.
Hey.